Good morning, good afternoon, good evening, colleagues from wherever part of the world you're joining us from. Thank you for joining this webinar. My name is Olaide Akoni. I am the Executive Director of Journalists Against AIDS based in Nigeria. I also serve as the coordinator of the Civil Society for the Eradication of TB, that's TB Network, based in Nigeria. So I will be your moderator for today's session of this webinar that is put together by the O'Neill Institute. And our topic is CD4 testing, the weakest link in the Cascade. Thank you all for joining. And I know that there are several meetings going on, but you have chosen to be a part of this meeting. And so you are warmly welcome. And as you know, the state of CD4 access is an area of concern that we will be addressing in this session today. CD4 testing is the gateway to advanced HIV disease care, and it is critical for accessing immune status, guiding clinical management, and identifying the risk of opportunistic infections. While CD4 testing was once the mainstay of national HIV programs, it has become neglected in the HIV response as viral load has become more widely available in many parts of the world. And so today we're going to be examining issues around CD4 testing and why it's the weakest link. And in the course of our discussions today, we are going to be looking at the WHO recommendations for CD4 testing. What is the current state of low CD4 coverage and usage across the world? And what are the examples of successful national advocacy and accountability mechanisms that are helping to address these issues and these gaps? And with me today, we have a warm and amazing panel of wonderful ladies who are going to be joining me to discuss these issues on the call today. And so very quickly, because I'm also very mindful of our time, we will be going into the first session. Like we said, today's session is focused on the state of CD4 testing. And as we go into the session, please, it's important to note that we would only be taking the questions and answers at the end after all of the panelists have spoken. But please note that the chat box will be open. So please feel free to drop your questions in the chat box. We will have people respond to your questions. But by the end of the session, when all of the panelists have made their presentations, we will now open up for Q&A. So please make sure to stay tuned till the end, but feel free to drop your questions and comments in the chat box. And we hope to see a very interactive chat box in the course of this session. So the way we're going to be going around the session is that we'll be having, first of all, a speaker who will be talking to us about the civil society plan of action on CD4. Then we will go and discuss CD4 policy landscape across Africa. Then we will talk more about the state of CD4 coverage and usage. And then we will also be having, lessons from the countries, country snapshots, common trends, implementation challenges, as well as community insight. So that is the outline that we will be following in today's webinar. So our very first panelist, I'm happy to introduce our very first panelist who will be talking to us about the CD4 plans. And our very first panelist is Sharon Ann Lynch. She is the co-director. Sorry, apologies. Sharon Ann Lynch is the co-director at Center for Global Health Policy and Politics at the O'Neill Institute, and she'll be presenting to us the civil society-led roadmap on CD4 testing, highlighting the key advocacy priorities and upcoming opportunities. So Sharon Ann, you have the floor. So a round warm welcome to Sharon Ann. She'll be presenting the civil society-led roadmap as well as the advocacy priorities and upcoming opportunities. Over to you, Sharon Ann.
Thank you, Olaide, and welcome everyone to the webinar that is hosted by the O'Neill Institute and the Fight AIDS Coalition. So I do want to just acknowledge that some of the people that are here today as speakers I've known for more than 20 years. And 20 years ago, if you had told us that in 2025, we would need to hold a webinar in order to address the low coverage of CD4 monitoring, I would have thought you were crazy because, as Olaide said, it has been the mainstay of HIV programs. It's how we know the state of someone's immune system and their battle with the HIV virus. So here it's even more important now that we know the advanced HIV disease and what it does to the body and the need to protect people from advanced HIV disease, including those killer opportunistic infections. So WHO has defined a package of care for advanced HIV disease. That package of care is supposed to be given to anyone who is stage 3 or stage 4, or whose CD4 is under 200. For children, all children under the age of 5 that are HIV positive are designated as having advanced HIV disease and therefore should receive the advanced HIV disease package of care as well. That package of care includes critical diagnostics. It also includes critical prophylaxis to stave off those opportunistic infections, including cryptococcal meningitis, which has got to be the most painful way to die, as well as tuberculosis. So I'd like to just pause there because, as Olaide mentioned, CD4 coverage and monitoring is a critical gateway to that AHD care. However, we know that coverage is woefully inadequate. So we're not even at the levels that we used to be 20 years ago with CD4. And one, because people have switched to viral load only. And of course, viral load is critical, but not at the expense of CD4. And secondly, because among the commodities, especially in the funding crisis, we find that governments are unfortunately deprioritizing some of the diagnostics, including CD4. Now, WHO just put out a statement today urging countries to use low-cost, quality diagnostics for HIV. This can include and should include CD4. It doesn't mention in their announcement, which is unfortunate. But CD4 tests we have include a point-of-care affordable test. That is Visitect. It's a rapid diagnostic point of care test, which is an advancement that we didn't have 20 years ago. So at this point, all the excuses should be removed, and we should be seeing more action on the part of national HIV programs and governments to scale up these essential tests. So CD4 monitoring, it needs to come back. It needs to be mainstreamed again in HIV programs, both for people that present to care. So in the workup for ARVs, once you've tested positive. And secondly, if someone drops out of care and then returns to care, there needs to be a CD4 monitoring test as well to determine, again, the state of the immune system in order to determine whether a person has AHD and whether they should be given the advanced HIV disease package of care. So just some things that can be done looking at where we are in the calendar. So right now, the Global Fund is contacting principal recipients. Unfortunately, they're not engaging enough with the country coordinated mechanisms around reprogramming of grant cycle 7, reprogramming, but also reprioritization. So CD4 did see an uptick in the funding request for GC7, nearly triple that from the previous round, which is great news. So finally, we see an upward trajectory when it comes to CD4. However, because of the funding crisis, this might be on the chopping block again. So we need to do more to make sure and engage with those principal recipients, even if they are not doing their due diligence in terms of doing outreach to communities and civil society, to insist that CD4 monitoring be seen as an essential life-saving commodity, because it does save lives. Secondly, every country will be going through an NSP review at some point. So those national strategic plans is where the goals should be enshroud in countries' ambitions in terms of coverage. So what are countries' plans? And civil society, activists, communities need to be there for those NSP reviews to make the case again and again that we need more CD4 usage and uptake. And in order for that to happen, they need to be available. So we need to have coverage across facilities. Every primary healthcare facility should be offering CD4 at this point. Thirdly, we'll be going into in 2026, the GC8, the Grant Cycle 8 funding cycle. That means that countries will be working up their funding requests to the Global Fund. And I don't want to be naive here. There will be a lot of competition for scarce resources given the funding crisis. However, we have to make the fight for CD4 to be included in funding requests at the level that is adequate, that is needed in order to have 100% facility coverage and 100% coverage for people entering into care and 100% coverage for those that are re-entering into care. So those are some of the advocacy opportunities in front of us. Please engage with governments, with CCM members, with your colleagues, with other civil society organizations and communities so that they, A, demand CD4 for themselves. Everyone should know their last CD4 count. And B, so that we can have this critical test included in the funding requests and in the NSPs at the level that is needed. Thank you so much, Olaide. Over to you.
Thank you so much, Sharonan, for giving us that overview and kind of giving us the heads up on the things that we need to do, as we review our NSPs and as we plan for, the country request and how to prioritize and ensure that, the demand for CD4 is front and center in the request that we're developing at country level. So taking us further on that conversation, I am going to invite Agrata Sharma, who is the associate at the Center for Global Health Policy and Advocacy and Politics at O'Neill Institute. And she will be working us very quickly through the CD4 policy landscape across Africa. She'll be giving us an overview of the WHO CD4 testing policies, as well as the state of the policy in Africa. Thank you, Agrata, over to you.
Thank you, Sharonan. Thank you, Olaide. Hello, everyone. Thank you so much for joining us today. I'm Agrita. I work at the Center for Global Health Policy and Politics, and I've been a FACT member for over 3 years now. To start with, we developed a fact sheet that you can see here titled CD4 Monitoring, Addressing the Weakest Link in HIV Cascade. You can download it by scanning the QR code on the screen, but I will also be sharing it in the chat with you all. So moving on. As an overview, I will be talking about 3 key things: the importance of CD4 monitoring, the WHO recommendations, and the state of policy in Africa. But before we delve into the importance of CD4 monitoring, let's just talk briefly about what are CD4 cells? I'm sure you all know, but just to kind of, make sure that we are all on the same page, CD4 cells are a type of white blood cells that act as alarm bells for the immune system. When they recognize a pathogen, so basically they alert your entire immune system to make sure that they come and eat the pathogen away and respond to the infection and the infectious agent. As CD4 counts decline, which is what happens during the HIV infection. The HIV virus eats away your CD4 cells. It weakens the immune system and increases the risk of opportunistic infections. And this makes CD4 a very essential marker of health and well-being for people living with HIV. But as Sharonan said, and as we all know, CD4 monitoring has declined considerably. There are several reasons to it, which we'll get into in a minute. But this has led to, this could be a very significant part of why the HIV deaths are plateauing, and we are far, far away from reaching our target of 250,000 deaths by 2030, because we're still, as you can see, we're still at about 63,000 deaths per year, which translates into 1 death every minute, which is a lot. And this is not where we thought we would be in our fight against HIV. And the reasons So the ongoing, as I said, the ongoing crisis is partly due to the suboptimal and delayed diagnosis of AHD, which leaves many people with HIV vulnerable to life-threatening complications and infections. And then research shows that relying solely on symptomatic screening for AHD without a diagnostic test to measure CD4 count could miss up to half of the cases. Research reveals that in sub-Saharan Africa, particularly 32 to 71% of all people living with HIV enter care with AHD, and up to 60% re-enter care with AHD. In addition, at CROI last year, WHO presented data from 12 countries showing that 2/3 of people on antiretrovirals are living with AHD, and almost half of them have suppressed viral loads. So this research showed that CD4 count and viral loads are not interchangeable. We need both, and both of them are very important. And these findings highlight that even when there is adherence to antiretrovirals, it cannot prevent AHD. And many people, even with viral suppression, remain at high risk of developing AHD, underscoring the critical need of CD4 monitoring at key stages, including entry into care, re-entry into care, even amongst those with suppressed viral loads. Um, so, evidently CD4 monitoring is crucial, as we've seen here. Then why has it not received the kind of importance that it should have in the past few years? So one of the reasons is that CD4 testing guidelines have evolved dramatically over the past 2 decades, as you can see in this figure. Initially, CD4 was one of the most important tests for 3 things: ART initiation, ART monitoring, and risk stratification. As the scientific evidence evolved, it became less and less important, and today we have universal test and treat, and then the viral load monitoring became the preferred tool for ART monitoring. So basically, what the role of CD4 was basically for risk stratification. But one of the key things that countries forgot was that the role of CD4 testing is evolving, and not that CD4 test in itself has become obsolete. One of the key things that happened with universal test and treat policy, we saw that there was a rapid decline in CD4 testing. As I said, the other countries thought that it's become obsolete and not required, which was seen in countries like Uganda, where baseline CD4 testing fell from 73% in 2013 to 21% in 2018, which is a reduction of about 52 percentage points in just 5 years. And similar trends were observed in other countries too, reflecting sudden deprioritization of CD4 testing in national policies, national and donor budgets, manifesting as a steep reduction in demand. Clearly, this is the time when we need to rethink how we articulate the need for CD4 testing itself. Today, as stated above, it is arguably one of the most important tools to diagnose AHD. Since 2017, WHO refers to CD4 as the gateway of AHD care. It is crucial not only for identifying people living with people living with HIV with AHD, but also screening and timely initiation of WHO recommended package of care for AHD. This package includes tests to rule out opportunistic infections, especially for the major contributors to mortality for people living with HIV. That's TB and cryptococcal meningitis. So tests like TB-LAM, CRAG, rapid diagnostic tests for cryptococcal meningitis. The package of care also includes fluconazole prophylaxis and guidance for appropriate antibiotics for severe bacterial infection. As you can see on the slide, WHO recommends CD4 monitoring for anyone entering care, re-entering care, to support the diagnostics, the diagnosis of treatment failure and people living with HIV in inpatient care. it is important to emphasize that Global Fund includes CD4 testing as a part of its program essentials. So program essentials are basically a set of prioritized evidence-based interventions aligned with technical guidance from global health agencies to support the scale-up of critical services and ensure equitable access. So basically saying that Global Fund thinks that it's one of the most important interventions for ensuring optimal HIV care for everyone. And then, based on the discussion above, it is clear CD4 is essential. It is also clear that there is a need to drum up demand. But how exactly can we do that? First and foremost, we can't fight what we don't measure. As demonstrated by the success of 95, 95, 95 targets, what gets measured gets done. To reverse the decline in demand for CD4 monitoring and its impact and rebuilding CD4 testing, three areas must be tracked and publicly reported. So first being the policy adoption, the implementation being the second, and financing being the third. So I will be covering the first section, which is basically the policy adoption aspect. We at GHPP, under the aegis of HIV Policy Labs, AHD policy dashboard, tracked two key metrics related to to CD4 in Eastern and Southern Africa and Western and Central Africa. So the first part is that the first question that we delved into was whether national guidelines require a baseline CD4 test and follow-up testing for all newly diagnosed people living with HIV. And the second one was whether national guidelines require a CD4 test for people living with HIV returning to care. So based on our data, as you can see right here, out of 17 countries in Eastern and Southern Africa, where documents were found, 16 countries adopted baseline CD4 testing, that is for anyone who was entering into care, while only 9 countries require CD4 testing for people re-entering HIV care. In Western and Central Africa, the policy adoption was even lower. Out of the 18 countries, 15 adopted baseline CD4 testing for people, while only 3 countries explicitly require CD4 testing for those re-entering care. So just before I wrap up, I just want to reiterate like 5 quick takeaways. First being that CD4 testing is critical and yet a missing tool to reduce AHD care, to reduce AHD related deaths. Second, WHO recommends CD4 monitoring for any person living with HIV entering into care, re-engaging with care, and who are in inpatient setting. Third, policy adoption is good when it comes to ESA over Western and Central Africa. Also, it's much higher for those entering into care versus those who are re-engaging in care. Fourth, we know that optimal policies are just the starting point. We need optimal implementation. The speakers after me will delve into the state of implementation, but it is clear that there is a need to drum up demand, and we need all hands on deck: the national governments, the global health actors, like Global Fund, and then of course all of us, the civil society here. And lastly, as we engage in conversations with global health actors like Global Fund, it's important to remember that CD4 is a program essential. It is a prioritized intervention to support and scale up critical services and ensure equitable access. Thank you so much. Now I'll hand it over to Olaide.
Thank you so much, Agrata. Thank you for walking us through the state of, the policy adoption in Africa, particularly for CD4. And like you rightly said, adopting policy doesn't necessarily translate to, implementation on the ground. And we really need to ensure that, this implementation is really taking root in many of our countries, particularly in West and Central Africa, just like you highlighted in your presentation. Like we mentioned earlier, for those of you joining us, if you do have questions, please drop in the chat box. We will be having a Q&A session at the end of all the presentations, but I see that some of our panelists are already responding to some of the questions that people are dropping in the chat box. So I encourage you to please maximize the utilization of the chat box. And so moving on very quickly, we're going to be going into our third presentation, which is on the state of CD4 coverage and usage. And I will be inviting our panelist, Anna Moore, who is the Associate Director, Advanced HIV Disease at the Clinton Health Access Initiative, CHI, who will be discussing the issue of the state of CD4 coverage and usage. She would also be looking at the global CD4 forecast, the CD4 need calculator, and the AHD commodity calculator. Over to you, Anna.
Yeah, thank you so much, Aleida. Next slide, please. As Aleida mentioned, I'll start with just a quick overview of the global CD4 demand forecast. And then I'll touch a little bit on the impact of the PEPFAR funding freeze on CD4. And then we'll go into a couple of tools that CHI has developed to support countries with calculating their CD4 need, and how this then fits into a broader commodity calculator for the AHD package of care. Next slide, please. One more. Thank you. So here I present a global CD4 forecast as of the end of last year. Every year, CHI produces the CD4 forecast, and for a number of years now, we have been seeing demand for CD4 testing dropping. From our latest forecast, again, which was developed last year before the US government funding freeze, we see a forecast demand of about 7.5 million tests per year and an unmet need of between 1.5 million and 3 million tests each year. However, as I'm sure many of you know, there has been a stagnation in AIDS-related deaths, and we continue to see 1 in 3 patients who are newly presenting to care having advanced HIV disease, and in some populations, this is significantly higher. As such, this forecasted demand does not reflect the true need or the true number of people who are eligible for testing. And I think Sharon already alluded to some of this. For this forecast, I also just wanted to note that the demand volumes are based on data collected by CHI and Avenir Health from 45 countries, which represent about 89% of adults living with HIV in low and middle income countries. Additionally, while there is a high proportion of testing taking place on conventional platforms, I think it is important for us to flag that a third of this conventional demand and testing is taking place in just one country, which is South Africa. So if we were to remove South Africa from the forecast, we would see that, in fact, the majority of CD4 testing is taking place on point-of-care platforms. And already from the chat, there's been quite a bit of discussion on point-of-care CD4 testing. And then finally, acknowledging my earlier point that this forecast uses actual data from 2023 and forecasts demand based on information available at the end of 2024, we do anticipate changes in this year's forecast, which will be published later this year. And I believe these slides will be shared. At the bottom of the slide, there is a link to this year's report. And yeah, like I said, later this year, we will publish an updated version of this forecast. Next slide, please. One more. Thank you. So I also just wanted to touch on the US government funding freeze. At the end of March, in response to significant uncertainty on the future of AHD and HIV programs more broadly, following the funding freeze, CHI sought to better understand the risks facing global HIV markets and to help countries assess the broader implications for HIV service delivery. We requested data on the stock status of key commodities from 14 low and middle income countries and combined this with the PEPFAR data that was published by UNAIDS, and developed an HIV market impact memo, which we published at the end of March. Here at the top left of the slide, again, is a link to the memo, if anyone is interested in that. And in it, we really highlight the impacts to the entire supply chain of the PEPFAR funding freeze, as shown by this illustrative example here. Next slide, please. So diving into CD4 specifically, as of the end of March, 10 countries were at risk of stocking out of at least one CD4 test in the next 6 months. This situation is particularly dire for Visitect and PIMA testing, for which countries had an average stock of 4 months and 5 months respectively. So just want to give a moment for that to sink in. From what we have been hearing, the situation is improving, but again, just really highlighting the situation that is facing countries right now, and how we really do need to advocate for continued support for CD4 and ensure that testing is taking place in all of the countries that we work in and are supporting. Next slide, please. So going back to the CD4 trends, like I mentioned, we are working on a revised forecast, which we will publish later this year. However, I am able to share data for 5 countries. While things may change as a result of the funding freeze, in the 4 countries for which I do have comprehensive data available, CD4 demand did increase by between 15 and 100% in 3 countries. And again, this is a very limited set of countries, but positive data, at least coming out of a few. That said, one of the 4 did have a decrease in CD4 testing by 16%. Additionally, what is really important to note here is the increased uptake of the CD4 test between 2023 and 2024, and the falling demand for PIMA and FACSPRESTO testing in response to announcement by these suppliers a couple of years ago that they are withdrawing from the market. Next slide, please. So moving on to some of the tools that we have been developing. The first is a CD4 need calculator. This tool helps countries to quantify their national CD4 testing need based off eligibility criteria and targeted access. As a default, the tool starts with a default baseline of data from the UNAIDS dataset. However, users can refine it with actual data from the national program. The tool produces a linear forecast based off 4 years of historical data applied to future years. And users can refine this forecast by editing a number of pieces, including attrition rates, non-suppression rates, tests needed according to national guidelines, also buffers for wastage or for repeat testing, and percentage of patients accessing viral load monitoring. This tool, we hope, will be helpful in providing countries with a common approach to quantifying their CD4 testing need, and it also allows donors and other global entities to compare need calculated in a similar way across multiple countries. Next slide, please. So this CD4 need calculator ultimately feeds into an AHD commodity calculator. This tool helps programs to quantify key commodities for the diagnosis and treatment of people with advanced HIV disease. Some of the input data includes data on the ART cohort, so number of new and existing patients, attrition rates, AHD access. And this is important. I think just going back to what Sharon Ann had said, while we hope that we can achieve funding and make funding available for 100% access, the reality on the ground is that access is quite lower. So I think this is also important for us to consider and avoid any wastage, especially where resources are limited. Import is also, users can also input on AHD assumptions, which include prevalence rates, rates of unsuppressed viral load, CRAG positivity, which treatment regimens are in place, and which proportion of patients will be accessing each of those. And then finally, the prices and pack sizes of AHD commodities accessed by the country. Both of these tools are housed on the global AHD toolkit and are available for downloading here. And if there are any questions or if any individuals or programs or groups would like us to support with a walkthrough of the test, we are very happy to do so. Thanks, and yeah, I will answer any follow-up questions either in the chat or the Q&A.
Thank you very much, Anna. Thank you really for taking us through the state of CD4 coverage, and as well as some of the tools that are available for use. And I'm sure for many of us, we've seen from Anna's presentation that there's been a plateau in the demand for CD4 forecasts, across many countries, and of course, there's also been a huge impact as a result of the funding, the USA funding freeze. And I think that's a food for thought for a lot of us. And we really need to go back to the plan of action that Sharon Ann had mentioned earlier, that, we need to keep ramping up demand for these tests, particularly in our country plans and in the funding requests as our countries prepare them. For those of you just joining us, again, want to say a warm welcome to you. This is the webinar that is examining CD4 testing, the weakest link currently, and how do we address the weakest link in the HIV cascade. And it is a webinar that is jointly put together by the O'Neill Institute, the Fight AIDS Coalition, and the Diagnostics Equity Consortium, DEC. So far we have listened to 3 of our panelists who have examined the different topics, and now we will be going into country perspectives. And in the country perspectives, we'll be hearing from 2 panelists who will be sharing from Kenya and from Malawi. What is the current situation in their countries? What are the common trends, the implementation challenges, and some of the community insights? And so to start us off in the country discussions, I'm going to be inviting Patricia Acero Ocheng, who is the team leader of Dandora Community AIDS Support Association, also known as DACASA, based in Kenya, and she'll be sharing some of the insights from Kenya. Over to you, Patricia.
Thank you so much, Olaide. Can you move the slide? Move it. So for Kenya, as Sharon had said earlier, as advocates, we really struggled to make sure that we had access to viral load testing, and we really pushed hard so that CD4 testing was put on the side. But due to the issues around AHD, Kenya has moved, and now we have a subcommittee on AHD. Me and other community members are part of that. So through that, they were able to take up the issue of mapping of the CD4 sites. And when they did the mapping, we realized that we had close to 366 CD4 platforms. But then there were issues with other platforms being phased out. So Kenya uses both conventional, which is Patek right now. We have around 95 machines. And then the point of care, the CD4 machine we have for testing, which is PIMA, we have 133. These are distributed in all the 47 counties in the high volume facilities. Out of the 378 facilities offering ART in the country, only 5.9% had a CD4 platform within the facility, and that is what is called the hub. That is around 288 facilities. 133 platforms from Presto have been phased out. So as you can see on the map there, we have, go back, Olaide, the time travels, the spoke and the hub. Yes, we have what they call the spoke and the hub. So from the spoke, those are the smaller sites where the samples are picked, and then these samples are taken to the hub. So sometimes this is distributed across the country. We have areas where people living with HIV are few, and the CD4 testing need in the region is also a bit lower. The issue of LFA, CD4 testing in the region, has the potential of decentralizing access to CD4 testing at the lowest costs. LFA, we feel that will reduce the turnaround time, thus enhancing faster decision-making for clinicians to manage AHD. By the time we were doing this, we still did not have access to the LFA. There was a challenge as a country that we had not done a pilot for the LFA. So it took us close to a year. From the whole of last year, there was a big challenge that the pilot was not done. But currently, the pilot has been done and it is finished. And we're being told that there's a possibility that we'll start using VSTEC by mid-June. Can we move? So currently in Kenya, we have counties that do not have PATEC, and those are Bomet County, Elgeyo Marakwet. You all know why PATEC is important, because of testing CD4 for children. So the PATEC is quite important because of children. So these are counties that in Kenya we do not have the PATEC machine, and that is Bomet, Elgeyo Marakwet, Isiolo, Kwale, Mandera, Meru, and Tharaka Nithi. Countries that do not have PIMA is Garissa, Murang'a, Nyandarua, Wajir, and West Pokot. So what are some of the strategies that we feel can be able to increase access to AHD laboratory diagnosis? Can we move to the next? Yes. So the strategies that we feel can be able to help us, one of them is mapping and placement of new equipment, engagement with local agents for placement for additional equipment. Abbott has committed the placement of additional 50 equipment to scale up later. PATEC committed to place in counties with no equipment and facilities that has calibras. The protocols have been approved, and now the stable supply plan. We need to have an accurate focus and quantification of AHD lab commodities. Resource mobilization, that one is from the government and the GF. Even before the stop work order, PEPFAR had been very clear that they will not be supporting diagnostics for AHD, but they'll support treatment. So that is why we are talking about the GOK, that is Government of Kenya, and Global Fund. Then the other area that we also feel needs to be very strategic is the issue about data and the data use. Strengthening lab and clinical interface to ensure reporting and no missed opportunities, having the AHD lab dashboard for end-to-end visibility. Those are areas that we feel strongly can be able to assist in making sure that CD4 is enhanced. The last one. So this is just a rundown on the LFA and the fact that we hope that the Global Fund will be able to give us the 78 tests that they had talked about, and that we'll soon having the rollout of the VSTEC. Yes, as Olaide had said earlier, as Kenya, we have the guidelines that were adopted from WHO, but it is true also that having guidelines, having policies does not mean implementation. So because as we are right now, the information we have is that we are at 6% in terms of CD4 testing. And that means there's a big gap, especially from the clinical side, that clinicians are seeing patients who are coming in the first time and they're not doing CD4. But things are now getting more complicated. One, because of the integration. The clinicians who had been trained to be able to take up to make sure that AHD services are being rolled, some of them have been sent home, although a few are now coming back. So again, in Kenya, we might be going lower than 6%. And as communities, I think we also have a challenge as advocates to make sure that our communities are well informed about AHD, that can be able to demand for CD4 testing every time they go to the facility, and they can be able to pass out that information. Because when new clinicians are brought on board, when services are integrated, it will take a while for the issues of AHD to go out. So the issue of integration to my colleagues, to the communities, to the clinicians, need to be taken with the seriousness it deserves, and that any training that is being undertaken, the issues of AHD have to be brought on board, so that even as we move toward integration, that we are not leaving AHD behind. So back to you, Laide. Olaide?
Oh, I think Olaide is frozen and has just, oh, Olaide is back on. Over to you, Olaide.
Sorry, I think I had a network challenge. Thank you very much, Patricia, and thank you for giving us very practical insight into what's going on in Kenya, and how civil society has also been following up with the processes to ensure that, we're not only just talking about policies, but there's also implementation, and there's also optimization, of the CD4 machines and the POCs that are available in country, so that people can benefit. I think a crucial issue that you also raised is awareness of the healthcare providers, and them being trained and sensitized, to provide these services. And that is a key point that I think somebody had also raised in the chat box that we need to keep an eye on. So moving on very quickly, I would like to invite Edna Tembo, who is the Executive Director of Coalition of Women Living with HIV and AIDS, COWA in Malawi, to also share some of the country experiences in addressing CD4 count testing services in the country. Thank you. Over to you,
Thank
Edna.
you very much, Aloide. Good afternoon, good morning, good evening to wherever you are. This is Edna Tembo from Malawi, presenting some information about Malawi. Next. Yeah, I'll start with the introduction that in Malawi, advanced HIV disease has remained a significant concern, though we have adopted the HD guidelines in our Malawi HIV clinical management, and also implementing in some of the ART sites in Malawi to address the needs of people living with HIV and also children. But still, we see a third of people living with HIV are presenting to care with advanced HIV with a CD4 count of less than 200. And in Malawi, CD4 test has also been overshadowed by the viral load test, as one of the presenters mentioned earlier on. Next. A CD4 facility coverage. In Malawi currently, we have 279 sites which are providing AHD. We have 136 hubs and 140 spikes. And this is out of 857 ART sites which are providing, which are in Malawi. So it means that some recipients of care are still not being able to access these services because their sites do not provide HD services. Next. Yeah, so this table indicated the availability of the CD4 diagnostic platforms according to Malawi status. At the central lab, at the moment, it's not applicable because these central lab are like referral, and most of the recipients of care access these services at tertiary, secondary, and primary. So for tertiary laboratory, currently we have PIMA machines, which are 4, and we have also 4 tertiary hospitals, which are in Mzuzu, Lilongwe, Blantyre, and Zomba. So all these tertiary institutions have the CD4 testing machines. And at secondary level, we have also PIMA in 27 facilities. And in addition to that, we also have our 92 PIMA machines at primary level. And these are selected health facilities which provide AHD. And some of them are mission hospitals, others are private hospitals. So in Malawi, we have a total of 28 district hospitals. So you will see that out of 28 district hospitals, it's only 27 district hospitals which have PIMA machines. Next one. And on testing coverage, among the people initiating on ART, we have 66.9% available data, which was derived from the Q2 2024, indicating people returning to care as well as initiating. At the moment, we have a challenge whereby capturing data tools do not disaggregate between coverage among new initiators and also coverage among returning clients. So this is just a lump sum of both initiating as well as returning to care. Next. Yeah, this also shows the number of CD4 tests carried out in Q2 of 2024. There were 9,292 tests conducted. Under PIMA, it was 8,944, and we only had 345 on Visitect. And in Q4, we saw a decrease of 10%. Whereby 8,341 recipients of care were tested. And for urine lung, in Q3, we had 2,220 tests conducted, while in Q4 of 2024, we had 3,779. So you will see that urine lung tests were 23% less than the number of low CD4 test results in Q3. So around 400 TB cases were contributed through lung diagnosis. And those initiated on TPT were 61%, an increase from the Q4 of 59%. And on CRAD, in Q3, there were 3,843 tests conducted, a 16% decrease from 2024 Q2. And in Q4 of 2024, we had 2,953 tests, a 5% decrease. And out of those 2,953, we had 188 positive cases. Next. So challenges affecting the implementation. Access to TB urine lung remains a challenge. For the past months, we had stockouts, which were due to logistical problems. And also on CRAD test conducted, a positivity rate continues to fluctuate, as you have seen the numbers which I presented on the previous slide. And most of the district continue to have high viral load suppression rates, but with low testing coverage on CD4. And also attrition between approved applications and samples collected remain a challenge, especially in the HIV drug resistant cascade. In Malawi, they have started testing on drug resistant on recipients of care who are on ART. So in some facilities, they are not providing the test because it has to go to the main platform whereby the drug resistant test is being done. So most of the health workers, they are not really skilled or have the courage to test people who are coming in with a high viral load for a long time. So that also is contributing a lot to people presenting with advanced HIV. And the other challenge is on data aggregation and management, whereby there's no proper data indicating whether these are initiating or those are returning back to care, as it is just lumped together. And also the AHD services mostly provided by partners. We were more dependent on donors or implementing partners of PEPFAR. So with the stop order, most of the facilities have been affected, and the services on AHD are really affected because they need now to train healthy workers as well as also manage the data and the laboratory. So human resource is also a challenge in providing AHD services currently. Next slide. This slide is just giving up an analysis on the challenges. The first one is high proportion of people living with HIV in sites with AHD screening capacity presenting with AHD. And the successes is 2/3 of eligible clients have access to AHD screening and management. But the key point is AHD continues to exist among people living with HIV, about 1/3 of them returning or presenting with AHD. And on the inconsistent supply of AHD commodities, e.g. TB, urine lamp, and Visitect, the success thing is that there is an upcoming procurement of Visitec from the GF resources, which will enable expansion of AHD services to more sites. At least we are now targeting to reach out to 65% of sites to provide AHD, and also to improve on data management so that our data is giving us proper information, and also disaggregation of recipients of care who are accessing the services. Next. Yeah, plans for Malawi. Malawi as a country is planning to roll out Visitec CD4 test to all facilities providing AHD services, and scaling up AHD sites to 471, upgrading the spokes, and also strengthening the HIV resistance investigations, as well as also training the AHD providers who will be able to scale down to facility-based training to increase the number of service providers, and also to improve on data management systems. And currently, with the stop order, Malawi Ministry of Health staff has taken over the responsibility to take lead of all the services provided in the facilities, as compared to the previous time whereby most of the services, especially under AHD and other opportunistic infection, was managed by implementing partners. So now they are going to take the lead, and then the implementing partners will just come in to support and build capacity of the staff. Next. Yeah. Call to action. We are calling on the government to rapidly transition to optimal treatment, especially focusing also on the children, to adopt also the WHO Stop AIDS package and to integrate it with the Integrated Management of Childhood Illness Program, which at the moment they are doing it separately. So opportunities of missing out children because most of the health workers are not using the Stop AIDS package to integrate it with the IMCI program. And also calling on the government to strengthen capacity, access, availability, and affordability to adequately screen, treat, and retain recipients of care, and also to equally distribute the diagnostics and the skilled human resources, as well as the commodities of AHD management in the facilities, and also to engage with the communities, because community is key. If communities are aware of AHD and also able to demand for the services, the Ministry of Health will be able to support. And we are urging for meaningful participation and engagement of people living with HIV, and also to engage on treatment literacy so that recipients of care are aware of the treatment and the benefits of treatment. Thank you very much for your attention.
Thank you so much, Edna. That was very detailed and very eye-opening, and I like how you ended it, particularly the emphasis on, engaging communities and the critical role that treatment literacy has to play in all of this. So a round of applause to all of our panelists. I'm sure you agree with me that they have done justice to the topics, and we will now be going into the Q&A session. I know some of the questions have been addressed in the chat box, but this is an opportunity for you to indicate with a show of hands electronically if you want any areas, gray areas to be addressed. But while we wait for a show of hands, there was a question in the chat box addressed to Anna, and the question is from Deepak. So I'll just quickly read the question and then Anna could respond to that while we wait for people to also indicate. So thanks, Anna, for additional good updates. We also love innovation and new technologies. However, it would be great if we could get the best possible return on investment by poor countries until new affordable technologies and facilities are readily available in the third world. So Deepak is asking about accessibility issues, also cost-related issues. So I know, Anna, you're trying to type, but maybe do you want to speak to the issue rather than typing?
Sure.
Yeah,
I was typing, so I may, after I finish speaking, just type it up so it's already there. But yeah, absolutely agreed, especially kind of with limited resources and with uncertainty around future funding for AHD. We really do want to ensure that we do have the best possible return on investment. And one of the immediate recommendations from the Nairobi declarations, as included in, in the fact sheet, is for programs to do a CD4 network optimization to determine the needs and optimize placement of available tests. I shared earlier a list of the available tests and their prices, but there are, of course, other considerations that need to be considered. These include investments in the technologies, training, service and maintenance, and other elements. That said, regarding kind of new and affordable technologies, we definitely would not recommend that programs wait for these new technologies because, yeah, if you've been monitoring the market in any way, you know that these can be delayed. And there is always a risk of pipeline technologies not making it to market. As such, given the urgent need for CD4 testing and for improving access, we would really recommend optimizing access to the tests that are available in the market. And then finally, regarding AHD more broadly, with of course CD4 being the gateway, I do believe that a WHO cost effectiveness study on AHD is expected to be published soon. And this does show investment in AHD to be very cost effective, second and marginally so only to scaling up antiretroviral therapy. So something for programs to think about.
Okay, thank you very much, Anna. So I also have a question here. I would want you, Anna, to respond and also probably have Edna and Patricia weigh in on it. It says that according to the CHI memo, CD4, CRAG, and TB-LAMB are prone to stockouts. Are there any mitigation plans in place at national, regional, and global level? Because we've also heard from the countries about stockouts here and there. How can we mitigate all of these issues? Your thoughts?
Yeah, this is a tough one. I think also, we've seen in many countries with the current funding freeze and uncertainty around future funding, it has impacted all elements of the PSM systems as well as healthcare workers who are actually collecting the data. So really for most immediate recommendation I would have is really to monitor stock status, and where facilities are at risk of stocking out, that those are flagged immediately and that they are prioritized. Second, at the national level, where countries are at risk of stocking out, whether it's hopefully not less than 6 months, but definitely if we are at risk of stocking out in the next 3 months, to really raise it at the global level. We're working through the APWG, the ARV procurement working group. That was mainly on the treatment side, but we are looking at adding commodities given all of the fluctuations in the space, and we can take these up to the supplier if programs are not already communicating that. But yeah, definitely it is a crisis and no kind of easy solution, but let's highlight the issues, let's make noise about it, and let's make sure that suppliers are prioritizing those countries that are at risk of stocking out.
Thank you. Let's make noise about it and let's prioritize it. So Patricia and Edna, how do we make that noise at country level so that, government is on its toes and ensuring that, these stockouts are averted long before they happen?
This Patricia.
What's your experience?
I think the most important thing for us is to make sure that we are part of the quantification teams, so that we are working with them hand in hand as they do the quantification for the AHD lab commodities, but also to push them to make sure that, for example, in Kenya, health is devolved, and sometimes these commodities are lying around at different labs, and maybe in that particular area, the use is not so high. That maybe there's a way using modern technology that they can be redistributed to where they're needed. And in terms of advocacy, that we are also working together as a country movement and also global movement to add to the noise that Anne is talking about at the manufacturing level, because our countries could have money and they don't know where to buy. So it has to be a double-pronged type of advocacy on us. Back to you, Lady.
Thank you very much, Patricia. That's really critical. Edna, any thoughts, any reflections on this issue?
I think I'll just agree with my colleagues that what we have to do is to be part of the teams, especially when looking at the logistics, and also at facility level. We need to take responsibility to see what is it that they have and how is their data like, because mostly if you want to place something like an order for the drugs or medicines, you really need to have the data that will back you up. But if data is not there, mostly for us, depending on the donors, they don't see the data, it's difficult to make an argument. So data is very important. And also to agree with Patricia, sometimes some facilities may have items lying and they don't know where to go with them or how to share amongst them. So that also system has to be really strengthened and monitored very well. Thank you.
Olaide, can I
Now,
come in on that as well?
Yes, please, Sharon, and over to you.
So I just wanted to point out that there is a flaw in the global health ecosystem. And it's regarding the Global Fund, where the Global Fund says that they're willing to move up orders, existing orders in the procurement process in order to respond to stockouts. But only that. And the reasoning is that they're not doing this catalytic procurement to fill the gaps because they want their money that they have to last longer. Now, of course, this doesn't make any sense. We've got stockouts of ARV regimens. We've got rationing of cotrimoxazole. We just heard about that's happening in Zambia, for example, where it's only for children. It's not being provided to adults that are being diagnosed with AHD. We've got stockouts of CD4 tests, of TB LAM, of basic HIV tests. For the Global Fund to say, no, we'll only speed up existing orders in the queue, it's simply not good enough. And as mentioned in that reprioritization, the communication that is happening now between the Global Fund and the principal recipients, CD4, as well as the rest of the medical tools as part of the AHD package, have got to be considered priorities. Otherwise, we're willfully blind to the people that need the most help in terms of based on the strength of their immune system, their ability to fight disease, which again, CD4 is one of the most effective ways to be able to gauge that. So thank you very much, Olaide, for the opportunity to provide that comment.
Thank you, Sharon. And so I see that Simon Collins, you have quite a number of questions in the Q&A chat box. Do you want to ask the question? So if you don't mind, if you could just raise your hand electronically so that your questions, you could ask the questions and then the panelists could address it. Simon, are you still on the call?
Yeah, can you hear me
Raise
okay?
your hands electronically.
Can you hear me okay?
Yes.
Yes, we can
Good,
hear.
great. Go ahead,
Right.
please.
So fantastic webinar. There's really important talks.
Yes,
really
we can.
helpful.
Please go ahead.
Thank you. Really important talks. Wonderful webinar. The two questions really is this is all about managing advanced HIV. And I think there's a really important and essential role of CD4 in order to triage people who will safely be able to stop ART compared to people who really shouldn't stop ART. And we already know that people are stopping ART because of closed clinics and stockout issues. So without CD4, some people are just going to progress really rapidly. And other people could actually go for years without having any clinical concerns. So that would really help with limited ART. That's one question. And the second question is anybody modelled this, the impact of having wider access to the CD4 count in order to be able to do this? I would write, if I haven't got enough drugs and I've got to have a little bit fewer drugs, that with more CD4 tests, I'd go for more CD4 tests. I would put the resources into ramping up access to CD4 count in order to manage limited ART supplies. So those two questions, thanks.
Thank you very much for the questions. So Anna, do you want to go first to respond and then we'll move around the panelists? Thank you.
Yeah, thanks, Simon. Oof, the second one on the modeling, I think this is a tough area to go into. I think if we now start rationing ART based off CD4 counts, it really takes us to a time before the test and treat recommendation from the WHO. So I don't think we would advise countries to go that route. But if we are seeing that rationing is taking place, that people are stopping art, yeah, I don't know if this is something, I don't know if there's anyone from WHO that can advise on this, but definitely I think country programs will need to make rational decisions here. But I don't think that there's a clear recommendation for this. Yeah, but yeah, I don't think we can and should support that to take place.
I would say it's already happening.
Yeah.
It's not formally happening in terms of rationing or limiting, but it's already happening in terms of people. You have way more people have stopped treatment than is being acknowledged.
Yeah. Yeah.
And if you used Uganda as an example, to hear that 5 years ago only 21% of people had a baseline CD4 count, this is where I'm hearing people are stopping treatment. Art that used to be free is now paid for. And if you can't pay for it, people stop.
Yeah.
And the two issues there are, one, people have got, they've no idea what risk they're at or how safe they are to save their money and spend it on food. Some people could do that. But there's also no awareness that 6 weeks after stopping art, your viral load will be crazy high. U equals U is gone, and the risk of transmission, we're just having, it's terrible. We are being dragged backwards. It's not that we're choosing to go backwards, it's using the information that we have from 20 years ago to plan this crisis situation. And we know that lots of people can safely stop art. And I wouldn't recommend that ever. I want everyone, I want universal art. I was on the START study. I want universal art. I believe in universal art. We're being dragged backwards, and I haven't seen any government commit to providing art for all its citizens in a PEPFAR country yet.
Yep.
And so there was the last, we hear that there's bribery going on or rationing, or I think we're already there. This is a crisis. Thank you.
Okay, Sharon Ann, do you want to weigh in on that?
I do,
Very
and I
quickly, and
agree
then
that
move on.
if ART is being rationed, just like it was in the early days, then those with the weakest immune systems need to be prioritized in the queue. However, we know that this isn't happening. So you've got people being turned away from facility if they're a member of a key population, for example, or those that aren't able to pay, as you say. So at least there should be this backup. And we know how to do this because it was, 25 years ago that there were more people in a waiting area that were eligible for ART, even under existing guidelines, than could be treated given what was available in stock and what based on what countries could afford. So we look to WHO to provide some guidance on that. Somebody from WHO was on the call that maybe could have addressed this, but I believe they're off now. But Simon, unfortunately, I agree. We are being dragged back to 25 years ago in terms of rationing. And at least that rationing needs to be rational and support the sickest and most vulnerable. Thank you.
Okay, thank you, Sharon Ann. So there's also a comment, it's more like a comment really, it talks about we need to advocate for at least baseline CD4 testing, and if possible, the yearly CD4 monitoring as well. And from what we saw in the policy landscape as presented by, Agrata, a lot of countries say, yes, we're going to do it, but implementation is not happening. So what should we be doing differently? I would like some of our panelists to weigh in on that. Maybe I'll start with Patricia. What can we do differently to ensure that at least countries focus on yearly CD4 monitoring as well and do what their policy statements have said they will do? How can we ramp up on implementation? Patricia.
One thing that can help us as advocates in terms of implementation, I think it's making sure that we push that in the guidelines, so that you demand for what you have in the guidelines, because that is what programs will tell you. That if it's not in the guideline, then they're not doing it. So I think our role is cut out, that if that's the way we want to go, then we have to make sure that that is captured in the guidelines. Back to you, Lady.
Okay, thank you. Agrata, do you also want to weigh in on this conversation? Because you gave us an overview of what the policy landscape is looking like.
Yeah, just to say that, of course, the policy landscape, one thing to flag is that it is better for people who are entering into care, but we need to kind of, ramp up our policy advocacy even when it comes to people who are re-entering into care, because there are several papers that suggest that, it's not a linear journey. People are in and out of care for several reasons, and, all of these policies should cater to the needs of those who are in and out and who are probably more vulnerable. So I think that aspect for sure. And then the implementation, as we've seen, is obviously lacking. And there needs to be ramping up of the implementation aspect of it all.
Thank you. Edna, do you want to weigh in on this, particularly the issue that Agrata touched about, people re-entering care and some of the challenges with them being able to access CD4 testing? What should we be doing differently at country level to make this happen?
I think we also need to build the capacity of the recipients of care so that they are also able to know, because the guidelines can be there, but if people are not aware of their right, sometimes they don't request for the service because they don't know. And most of the times our health workers are overwhelmed and they might ignore it deliberately, or sometimes they don't want just to do it. So if also people living with HIV or recipients of care are capacitated, and so that they know that when I have this condition, I need to also request for this test. Yeah,
that's a very, very important point. It goes back to the final point you had raised on your slide about treatment literacy as well, that people need to be aware of the test and the services that they need, and they're very aware enough to be able to demand those services when they require them. Thank you very much. We are running to the end of the webinar, but before we wrap up, maybe I'll just invite our panelists, maybe final thoughts, parting shots as we wrap up. So I'm going to ask Sharon Ann, final thoughts. We've talked about the weakest link. How do we address it? And then we'll go on to all the other panelists. Over to you, Sharon Ann.
Thank you, Olaide. This is indeed the weakest link, and it's what lets people fall through the cracks, so to speak, both in terms of getting onto ARV therapy without having a full workup, missing that opportunity to provide that life-saving advanced HIV disease package of care that you heard about from Agrata. That includes a testing for cryptococcal meningitis, which is the CRAG test. It's an antigen test. It's a rapid diagnostic test. It is very cheap. It's cheaper than a toothbrush, for crying out loud. And then also TB-LAM. TB-LAM is our only point of care rapid test that exists right now for TB. And it works with people who have advanced HIV disease. It's recommended to be in every primary healthcare facility, but it's not. and it's not being used for people who have advanced HIV. It also should be used universally for every person living with HIV who is in hospital. So for every inpatient, it should be used. In addition, you heard from Agrata about the importance of prophylaxis, so cotrimoxazole that can stave off a number of opportunistic infections, including cryptococcal meningitis, including PCP. And then again, we need TPT, TB prevention therapy for those, every person living with HIV should have TPT, but especially those with advanced HIV disease. So this package of care can help people stay alive and healthy. So the second place where we're missing CD4 monitoring that you've heard about are those returning to care. We know that life gets in the way of treatment. We know that for those facilities that still require monthly visits or have now had to revert back to monthly visits, it is difficult to fit treatment into people's lives, whether because of accidents, funerals to attend, natural disasters, weather, bridges being wiped out, regardless of the reason. We need to make sure that we have a safety net for people who drop out of care and then present again to care, to make sure that we know whether they have advanced HIV disease and whether they are eligible and should receive the advanced HIV disease package of care. We know the importance of treatment literacy. We know the importance of people living with HIV. Anyone who is on this call, you know what your baseline CD4 test was if you had it, because you know how proud of yourself you are to see that go up. You know your viral load status, and if you don't, then I encourage you to get both CD4 monitoring and your viral load testing. I want to thank everyone for joining the call and also invite you to join two activist efforts that are robust and underway. One is the Fight AIDS Coalition. These are activists who are fighting against unnecessary mortality and morbidity. As Agrata said, we have reached a plateau in terms of AIDS deaths every year for the past 4 years. There have been more than 600,000 AIDS deaths, and this has to be reduced. In addition, there's the Diagnostics Equity Consortium. So you could join the Fight AIDS Coalition that is focused on HIV, or the Diagnostics Equity Consortium that includes HIV, TB, and other diseases, where we fight for equitable access to that package of diagnostics that should be at the primary healthcare level, the secondary level, and the tertiary level in order to provide essential gateways into care. So thank you again, and keep up the fight. This is essentially a critical time. The reprioritization of Global Fund GC7 grants is not going to be easy. So please make your voices heard in that process. Thank you.
Okay, thank you, Sharon. We really are on, we're on time now, and we just have 1 more minute. So I apologize. Maybe we may not be able to take feedback from all the other panelists, but I think the message is clear. We need to keep our eyes on the ball. As country plans are being developed, we need to be strong in our request to countries to ensure that, they as well as those who are re-entering treatment, and a whole lot of the other issues that our panelists have raised. Just want to say thank you very much for attending this webinar, and I hope you have found it very useful and insightful. And please feel free to explore the tools that I believe Anna had dropped in the in the chat box, some of the tools that have been developed by Chai that you can also learn more about and get to be informed about. So thank you all for joining this webinar, and on behalf of the O'Neill Institute, DEC, as well as FAC, we want to say thank you very much for attending, and do enjoy the rest of your day. Have a lovely day. Bye.